Oh, I see. I'm sorry. I was wondering what that was about. Okay, we're being recorded. So what I want to tell you about is trends in pregnancy-related mortality in the United States, 1987 to 2014. These are the numbers of mothers who die within 1 year of giving birth, and it's the numbers per 100,000 live births. And it increased from 7.2 in 1987 to 18.0 in 2014, which is a very substantial increase. It more than doubled in about 30 years. When we look at the United States, we see an enormous racial disparity, and I'll just give you that data. The data are averaged for 3 years and reported to the CDC that way. So for the pregnancy-related mortality deaths, and not all these deaths were pregnancy-related, there were 12.4 deaths per 100,000 live births for white women, but there were 40.0 deaths per 100,000 live births for black women. So that's where we get the astounding figure that maternal mortality is more than 3 times higher for black women than it is for white women. And when we look at women of other races, it's 17.8 deaths per 100,000 live births, which is almost 150% of what it is for white women. We do not have a death rate for Hispanic women. And the other thing we can look at in the next slide is the trends and estimates of maternal mortality by country. And these data run from 1990 to 2015. And what you can see here is that the United States is the only country on this list where maternal mortality is increasing. It increased 16.7%, almost by 1/5 from 1990 to 2015. All other countries have either declined or stayed the same, and Canada stayed the same. And if you think Canada is like the United States, notice that their maternal mortality is only half of ours. Of course, they do have universal health care, and they've had it for quite a long time, and they have very generous parental leave as well. But every country is lower than ours. Spain is the best, and Sweden, and another excellent one, Germany, and then France is at 8 per 100,000, and the UK at 9 per 100,000. But all of them have been decreasing between 1990 and 2015. So it really would be very important for us as a country to figure out why we're increasing and why we have this enormous racial difference. So here we're going to start our webinar with the experts we've invited to present. And the first one is Julia Goodman. She has a PhD in economics and a master's in public health, and she's now at the Portland State University School of Public Health in Portland, Oregon. Julia.
Thank you, Heidi, and thanks to IWPR and the African American Policy Forum and RWJF for inviting me to contribute to this really important and timely webinar. I'm going to start out by talking about paid family leave in this country and how it might contribute to this terrifying maternal mortality, the statistics that you just heard about. There we go. So why are so many women dying in the U.S. Compared to other countries? And in particular, why do we have this appalling racial disparity? There are a lot of reasons for this, and we're not going to get into all of them today, but we're really starting to understand the role of structural factors, like paid family leave, for example, that influence both things like access to appropriate and timely health care, as well as toxic stress in the perinatal period, and really starting to understand more about the influence of stress on perinatal outcomes. And all of this, we should say, is happening against the backdrop of institutional racism that women of color face in the healthcare system in the U.S. So we know that women who receive no prenatal care are 3 to 4 times more likely to have a pregnancy-related death than those women who do receive prenatal care. And about a third of African American women do not receive the recommended number of prenatal visits, compared to about a quarter of U.S. women overall. We're also starting to see the importance of inadequate postpartum care to these high rates of maternal mortality in the U.S. So more than half of pregnancy-related deaths in the U.S. Are actually occurring after the birth of the child. And beyond that, there are many women who are experiencing serious postpartum complications in this period, in addition to the much more common difficulties like challenges initiating breastfeeding, postpartum depression, things that are much more common but are occurring in this postpartum period that is often neglected. Despite all of this, we know that what used to be recommended as just a single standard 6-week postpartum visit for mothers is pretty poorly attended. We have little information on this, but it looks like as much as 60% of women are missing that postpartum visit. And this is especially true for women who have limited resources. So we can imagine a lot of different reasons why having adequate prenatal and postpartum care would influence maternal health. But it's important to just call out the specific contribution of things like chronic health conditions and how dangerous this time can be for women who aren't able to carefully manage chronic health conditions that may have existed before pregnancy, but that certainly can be exacerbated during this time. So why is it that so few women in the U.S. are getting the care that they need, both prenatally and in the postpartum period? Well, as you can see in this map that many of you may be familiar with, the U.S. stands out as one of only 2 countries in the world that doesn't have any paid maternity leave. And because of that, only about 15% of workers in the U.S. have access to paid leave through their employers. This is something that the medical professionals are starting to recognize as they're calling for improved postpartum care. So for example, when the American College of Obstetrics and Gynecology, or ACOG, last year called for a new paradigm of postpartum care, one of the things that they recommended was 6 weeks of fully paid leave. Soon after this, there was a commentary published in the New England Journal of Medicine that was really drawing out this connection between paid leave and the ability to obtain postpartum care. And so we're starting to see this increasing recognition of the structural factors that influence women's access to care and their subsequent health outcomes. This is all happening on top of a growing body of evidence that's linking paid leave directly with health outcomes for mothers and babies. So this includes things like increased breastfeeding initiation and duration, decreased infant mortality, improved maternal postpartum health, mental health. There's a lot of evidence that links these kinds of policies to better health outcomes. There are also a few studies that are starting to try to make the connection between leave that's taken during pregnancy and health outcomes, although evidence in this area is a lot more limited. For example, Gwendelman and her colleagues did a study about 10 years ago and found that women who took antenatal leave in the last month of pregnancy had 4 times lower odds of having a cesarean section. This is an interesting finding and hasn't been replicated yet, but others are starting to look at expansions in paid leave policies and have found some links to improved birth outcomes. And the suggestion is that that could be through things like increased antenatal leave taking. So having access to more generous leave in general means that people might be more likely to use some of that during pregnancy, and that could potentially allow for more time for medical care, for going to those prenatal visits. Or it could happen through a reduced stress mechanism, directly affecting birth outcomes that way. So paid leave is potentially an important strategy for improving maternal health, but access to paid leave is highly uneven in the U.S. Most people, to the extent that they can access leave at all, access it through their employers. And what kinds of employers are offering leave are very diverse. So access to paid leave is generally higher among higher income workers, among managers and professional workers, among full-time workers, and among those who work for larger firms. So you can imagine that more vulnerable workers are often left out of the employer-sponsored leave policies that we have available. And though we don't, as I just showed you, we don't have any federal paid leave policy in the U.S., we do have a lot of state and local governments that are starting to step in and try to increase access to leave. So we now have 6 states plus the District of Columbia that have passed paid family and medical leave laws. From what we know, it seems like these do increase leave taking on average in a population. So when you have a state level policy that says we have to provide access to leave, more people tend to take leave. For example, I did a study a couple of years ago that looked at women who live in states that have paid family leave policies and temporary disability insurance policies, which are policies that cover pregnancy disability and allows women to take leave during pregnancy. Comparing women in those states to women in states that didn't have either of those policies. And women who had access to those policies were much more likely to take leave during pregnancy. So it seems like there's some effect of having access to those policies at the state level. But one of the challenges that we see is that none of the state policies that we have in existence right now provide fully paid leave. All of these policies provide somewhere between half and 2/3 wage replacement. And so there's really still a concern that the benefits of these policies are concentrated among relatively advantaged workers who can take advantage of a partially paid leave policy. An exception there is San Francisco, which recently enacted a paid parental leave ordinance that provides fully paid leave, and this is the first in the U.S. And thus far the only in the U.S. Policy that provides fully paid leave. I'm working with colleagues right now at UC Berkeley to examine whether this had an impact on leave taking, especially among lower wage workers. So hopefully we'll have some results to share with you all in the next couple of months. The last thing I want to mention about access to leave is that these policies are a really important first step, but they're not enough. We also need to think about how these policies are implemented within organizations and making sure that they're implemented in a way that's equitable. My research team here in Oregon has just wrapped up a mixed methods study of a new paid parental leave policy in Multnomah County. And we found some really striking differences in how people experience the same policy. So people who work in the same organization have access to the exact same paid parental leave policy, had very different experiences in actually trying to use it. So for example, there was differential support from colleagues and supervisors when trying to actually take leave. We also found things like employees of color reporting that they were much more likely to report that the timing of their return to work or how much time off they took after they had a child was influenced by a fear of losing their job or from pressure from their employer to return to work. So these are really important factors that are happening at the organizational level that sort of trickle down from policies happening at the local or the state level. I want to close by just highlighting a couple of serious gaps in the literature and putting out a call to any researchers who are listening in today to consider focusing your attention in these gap areas. So one concern here is that there's really relatively little research on how paid leave affects maternal health. There's quite a bit looking at infant health outcomes and even starting to look into child health outcomes, but there's still relatively little that looks at mothers. The exception to this, I would say, is postpartum depression. We have a pretty robust body of literature that is looking at the relationship with postpartum depression, but there is essentially nothing that looks directly at maternal mortality. And I think extending that a little bit, it's really important to look at some of the mechanisms that might link paid leave policies to improvements in maternal mortality, for example, healthcare utilization in the prenatal and the postpartum periods. And then the second area where I think there's really limited evidence is looking at the connection, or looking at access to paid leave in general, trying to understand what are the disparities in access to leave taking, but particularly focusing on African American women. And looking beyond just access on paper, access in terms of what policies you're covered by, but looking a little bit deeper into how are people experiencing these policies when they go to try and use the benefits that are available to them. So with that, I will close. Thank you all. I look forward to your questions.
I think we're going to be doing the questions after all the presentations. So the next presentation is by, but thank you, Julia. It was a very good presentation, very clear. And I'm very glad to hear about the Association of Gynecologists and Obstetricians. We've been waiting for the medical groups to get on board with paid family leave and paid sick days. So Radha Dagar has a PhD and an MPH also, and she is now at the National Institute of Health in the Division of Clinical and Health Services Research, working specifically, I believe, on racial and class differences in healthcare, if I'm not mistaken, on health disparities, minority health and health disparities. And the title of her presentation is Maternity Leave and Postpartum Depression, Implications for Maternal Mortality. Radha, I call on you next then.
Thank you, Heidi. I'm really happy to be and honored to be part of this really important talk or webinar on this topic. So good afternoon to everyone who's listening, and thanks for tuning in. My presentation is titled Maternity Leave and Postpartum Depression, Implications for Maternal Mortality. I would like to add a disclaimer that the views presented in this talk are solely my own and do not represent the views of the National Institutes of Health or the United States government. So why postpartum depression? First, this debilitating mental disorder affects 10 to 15% of all pregnancies. It begins in the first 4 weeks after childbirth, but may start as late as 3 or 6 months. It has been shown to have negative effects on maternal quality of life and her intimate relationships, on maternal-infant interactions, and also long-term effects on children's emotional and cognitive development. In extreme cases, the potential exists for suicide and or infant homicide. The symptoms of postpartum depression may start with as mild symptoms as fatigue or insomnia to loss of interest in life and suicidal ideation. These symptoms may be severe, persistent, and if untreated may last beyond the first postpartum year. So some of my previous research on work and postpartum depression has showed that higher psychological job demands, lower schedule autonomy, or basically lower control over one's schedule, and lower perceived control over work and family were associated with worse postpartum depression scores 3 months after childbirth. Another study showed that lower job flexibility and higher total workload, or basically total workload is the combination of paid and unpaid work, over the first 6 months after childbirth were associated with worse postpartum depression scores. In another study, among employed mothers, those who were depressed incurred 90% higher health services expenditures than non-depressed mothers. So this disorder is costly both for women and their employers. Now, the study that I'm going to be talking about today was published in 2014 in the Journal of Health Politics, Policy, and Law, and one of its aims was to investigate the impact of duration of leave taken from work on employed women's postpartum depressive symptoms over the first year after childbirth. The theoretical framework that was guiding this study was a hybrid model of health and workforce participation adapted from Becker's household production theory and Grossman's health production function. Its main assumption is that women's postpartum depression is a function of predetermined factors such as demographics, in addition to personal choices, for example, duration of leave. So basically, women may choose the duration of leave from work after childbirth as an input to the production of their postpartum health, subject to constraints such as income and employer leave policies. So who cares? First, employed women care about their health and what affects their well-being, and it's also important for their role as family caregivers. Employers are charged with implementing the Federal Family and Medical Leave Act and any state leave policies. They also must address dramatic changes in the labor force participation rates among mothers of infants, which rose from 38% in 1980 to up to 54% in 2005. Policymakers would also be interested in the study findings, given the current federal law that is basically the Family and Medical Leave Act, which provides 12 weeks of unpaid job protective leave and continued coverage of health care premiums for eligible employers and employees. Also, in addition, 6 states and Washington, D.C. have passed paid leave laws. And there are 18 states that have proposed paid leave laws as well. There are also 4 proposals that were introduced in 2019 on paid leave. The first one is the Family and Medical Insurance Leave Act, which was reintroduced in February 2019. And it basically provides U.S. workers with up to 12 weeks of partial income while being on family leave. The Federal Employee Paid Leave Act would guarantee 12 weeks of paid leave for federal employees to witness the birth, adoption, and fostering of a new child and care for a new child or family member with a serious medical condition or their serious medical condition. There's another bill that was reintroduced in March 2019. It's called the Economic Security for New Parents Act, and it allows parents to use Social Security benefits for paid family leave up to 2 months. Finally, President Trump's 2019 budget proposal includes a plan for paid family leave for new adoptive or biological parents that provides 6 weeks of paid leave using the unemployment insurance systems as a base. Okay, so what were the methods for this study? This was a longitudinal study that basically enrolled women from the 7-county metropolitan area of Minneapolis and St. Paul, Minnesota, who had a live birth in 2001 and were 18 years and older. The 3 selected hospitals were St. John's, North Memorial Medical Center, and St. Joseph. The total number of births in these hospitals were 2,736 births. Now, 32% of these births were eligible based on selection criteria such as the employment criteria, having a live single birth, and a baby with no complications, and being able to speak English. And basically, 29% of eligible women refused participation either due to lack of time or because they were not interested in the study. And that left us with a 71% enrollment rate, which is a total of 817 moms. As you can see in this figure, the follow-up rates were pretty good up to 12 months after childbirth.
Great.
So what were the characteristics of the sample? So the women were on average 30 years old, 73% were married, 86% were Caucasian, and half had a college degree or higher. In terms of work characteristics, 46% worked in professional jobs. They had worked on average 37 work hours per week, and about half of them were back to work by 12 weeks postpartum. We used the Edinburgh Postnatal Depression Scale to measure postpartum depressive symptoms at each time point. And basically, this is a scale with 10 short statements that ask the mother how she felt in the past 7 days. So starting with able to laugh and see the funny side of things, to thoughts of harming myself occurred to me. Now, this kind of study brings its own estimation problems. So the first one is omitted variables. So we could have a variable like support with childcare, which would confound the relationship between leave duration and postpartum depression by being related both to leave duration and to postpartum depression. There's also the problem of reverse causality, where basically leave duration taking could affect postpartum depression symptoms, And also, postpartum depression symptoms could potentially affect the duration of leave that the woman takes. So that results also in bias and estimation problems in just the regular OLS regression. That's why we use two-stage least squares regression in order to address these potential biases through instrumental variables. We also controlled for prenatal moods of depression and anxiety, demographics, and the time period. So we tested two instruments for leave duration. The first one was maximum available duration of paid leave according to employer policy, and that one was significantly predictive of leave duration taken by the mother. Similarly, the maximum available duration of job-protected leave, whether paid or unpaid, according to employer policy, was significantly predictive of leave duration taken. As you can see here, the two-stage least squares regression results showed significant relationship between leave duration and postpartum depression, and also showed that there's a non-linear relationship between leave duration and postpartum depression. And to do that, when we solve the equation with, we differentiate postpartum depression with respect to leave duration, we find that postpartum depression is minimized at 180 days or 6 months of leave duration. This means that there's a U-shaped relationship between leave duration and postpartum depression. So in the first postpartum year, every additional day of leave after childbirth is related to a decrease in postpartum depression symptoms up to 6 months. After that, that relationship reverses, and every additional day results maybe in higher depression symptoms. As you can see in this figure, you can see this kind of U-shaped relationship, because if you see the blue bars, these are women on leave who had lower depression scores at 6 weeks, 12 weeks, and 6 months. But at 12 months, that relationship has reversed. So this was the first longitudinal study to investigate the nonlinear relationship between leave duration and women's postpartum depression over the first 12 months after childbirth using the EPDS scale. New mothers taking leave from work less than 6 months after childbirth appear to have an increased risk of postpartum depressive symptoms. Duration of employers' paid leave and job-protected leave both predicted the duration of leave that mother took. So these are two important variables to consider when thinking of what affects the duration of leave that mothers take. This study highlights the importance of leave as a protective factor for maternal mental health at a critical time in the life course of women and their families. Subsequent studies on paid leave and postpartum mental health showed similar findings. For example, an Australian study of 2 cohorts pre and post implementation of a universal 18-week paid maternity leave policy, which was, I think, implemented in 2011, found that women in the paid leave group reported significantly better mental health than women in the unpaid leave group. Also, in California, after implementing paid leave, a study found that mothers experienced at least a 29% reduction in mean psychological distress symptoms after the enactment of paid leave. Those effects were most pronounced for Black, single, and low-income mothers. So how do these findings relate to maternal mortality and disparities? Although we don't have specific studies that look at leave duration or other other work policies that in relation to maternal mortality, we have some of the facts that could tell us, well, maybe there's a relationship and maybe we should look into it. So first one is suicide is the 7th leading cause of maternal death within 6 months of delivery. Suicidal thoughts and thoughts of harming the baby are symptoms that postpartum depressed women may experience. Some studies point to higher rates of postpartum depression among Black and low SES mothers, although until now we don't really have a national study to be able to make sure that this is a nationally representative relationship. Also, as my colleague Julia has or actually it was, I think, Heidi that mentioned that Black mothers in the U.S. die at 3 to 4 times the rate of white mothers, according to CDC statistics. So if we also look at disparities in access to work benefits, we find that Blacks and Latinos have the lowest access to paid sick days, paid parental leave, and paid vacations. Also, in terms of access to job flexibility benefits, Latinos and Blacks have the lowest access to job flexibility policies. This tells us that future research should probably examine the association between disparities in access to supportive work policies, such as paid leave, job flexibility, and maternal mortality. And potential mechanisms could be increased severity of postpartum depression, preeclampsia, stress, among others. Also, we should examine the Hispanic paradox of lower maternal mortality despite having the least access to supportive work policies. This could be due that they have stronger family support networks that may help during the period after childbirth. And finally, examine the contribution of untreated postpartum depression to maternal mortality and to racial disparities in mortality. Thank you, and I look forward to your questions.
Thank you very much, Radha. Again, an excellent presentation, chock full of information. I don't want to say that all of it's depressing because you are pointing to a potential solution, as Julia was also. So now we get to hear from our third panelist, Joya Creer-Perry, who has a medical degree. And I'm afraid I don't know what FACOG is, Joya. Maybe you can tell us.
No, it's just a lot of letters. Good afternoon, everybody. Hi, I'm Joya Creer-Perry. I'm an OBGYN by training, so that's what those letters mean.
Okay.
Okay. And I'm happy and proud to be here, and thank you so much for inviting me, and thank you to the African American Policy Forum. I got to participate last year in this week of Her Dream Deferred, and so to do it again this year, even if it's through a webinar, is an exciting opportunity. So thank you all again. All right, so we are going to talk about maternal mortality as a human rights imperative and a reproductive justice issue. So as you hopefully know, if you do not know, the United States was not founded on and nor does not continue to have a human rights framework. In the beginning, from the very beginnings of our country first, both women and Black people were not considered to be fully human, right? We were not able to buy things, own things, transport things without submission from others. So when you have a human rights framework, you believe that all people have the ability to live to their full potential. So that's a very different idea. So in our country, we not only don't have a access or a belief in a right to health, we don't even have a right to education. That's not something that's guaranteed by our federal government.
Excuse me, Dr. Creer-Perry, could you possibly speak up a little more loudly?
Yeah.
Some people have said they're having a hard time hearing you.
Okay, great. Can you hear me better now?
Yes.
Okay, great. Thank you. All right, so reproductive justice was created. It's a framework that we use and are expanding now that was created and backed by Black women in the 1990s, and women of color built upon it, really in response to the first iteration of healthcare reform. As we were discussing, what are the things we needed to ensure that we were healthy, and there was a lot of consideration around access to birth control and abortion, but there wasn't a lot of talk about the things that we need to fully be able to live in a human rights framework. And so those things that we need for reproductive justice are the ability to maintain personal bodily autonomy, to have children, right? So if you want to have 8 kids, you don't get to stop us from doing that. To not have children, so we're not only valuable based upon us having a uterus and being able to birth, and to parent the children we do have in safe and sustainable communities. So that is really important. So I want you to worry just as much about my 8-year-old son playing in a park with a toy gun as you do about me being able to get access to birth control, because all of that is a part of my reproductive justice. And so in order for us to really think about what we can envision, and we talked about earlier with paid leave and depression and all the things that impact maternal mortality, we have to have a vision for reproductive justice for all of us, because we won't get to any conversations around paid leave or working on reproductive maternal mortality if we don't reframe it from something that healthcare is benefit, but something to what our systems need to be held accountable for. When we started, we worked really for a definition. We get to do a lot of technical assistance and working with organizations. We really should look at what health equity means to you. This is a definition that was co-created with the Louisiana State Health Department alongside my organization. And really, for them, it means everyone has a fair and just opportunity to be healthier. So those are going to be things like access to paid leave, right? So even if 60% of people aren't going to their postpartum visit, one of the reasons could be paid leave. Another reason might be that when they get there, they're treated poorly and not seen as fully valuable. So how are the ways that we're looking at having both fair and just opportunities to be healthier? To quote our amazing leader from the African American Policy Forum, you have to acknowledge intersectionality. You have to center the most marginalized communities. What is it like for a transgendered man to have a baby in rural Louisiana? Like, that is the person that you really need to think about when you're creating your policies around leave, around maternal mortality, and all the barriers to their ability to live fully and to be seen fully. Accounting for structural racism, looking at both culture and place, that looks at rural and urban and all the in-between. And then really understanding the social determinants of health inequities, right? So social determinants didn't just pop up. We don't all live in neighborhoods because we chose to live there. We had federal policies along with local policies that still continue to this day that cause segregation and cause us to have social determinants of health inequities. When we created the National Birth Equity Collaborative, we did not have a definition for birth equity. We had definitions for equity in general. We have worked, so we really sat down and said, well, what does birth equity mean to us as an organization? And really, there are a lot of definitions around equity that imagine a place, right? That we will come to this place where all things are held equal and we will all hold hands and sing Kumbaya, and we'll have access to paid leave and mental health care services, and everybody will be healthy. But we recognize the same folks who fight for us to have inequitable resource will continue to exist. So perhaps it's not that there will be this place, but we need to put the assurances in place. The assurances, the policies, big P, and the policy, little p, of the conditions, right, or the social determinants, or all the things that you need for optimal birth. We don't want women to just survive pregnancy, to say, woo, I made it through that. We want them to thrive, to have the optimal birth that they wish. And it's for all people, right? So that means you have to have a willingness to address both racial and social inequalities in a sustained effort. So that means a 2-year grant cycle or a rapid cycle quality improvement or any of those things are going to fix it. It's going to take all of us to recognize it's going to be a sustained effort. It took us 400 years to get here. We're not going to end it with a 2-year grant. So be in it for the long haul. So this is one of my favorite slides just because it really points out that although we've been working on social determinants of health, and this was created by the Michigan Public Health Institute based upon a book by Richard Hoflicher around the social determinants are really midstream. When we started these conversations back in the late 90s, early 2000s, where we looked at high psychosocial stress and unhealthy behaviors and things like people not being able to make their prenatal care appointments and said, well, what are the reasons why? They're not just showing up because they don't like doctors, although that might be one reason, because we do have a distrust for the healthcare system, rightfully so. What are the other reasons besides people's just personal choices that allow for blocks and an inability to be healthy, that causes a disparity or an inequity in a distribution of disease, illness, and well-being? And so those things are things like safe and affordable housing, living wage, quality education, transportation, availability of food, social connection and safety. It was mentioned earlier that I love some of my Latina sisters as they have still are able to maintain a lot of their social connection, and we would like to be able to continue that and not break down and have laws and rules that break families apart, that cause harm and cause you to start seeing these increases in maternal and infant mortality and having job security. So you still can't hear me? I'm sorry. Is it better? Maybe I should put you.
Are you on a cell phone? You might be on a cell phone.
speaker. Yeah, is that better? Yeah. Can you hear me better?
Yes, thank you.
Okay. So above these social determinants, though, we have a power and wealth imbalance. And that are things like our labor markets, our housing policy, our education systems, our social safety net, our deregulation. We see that now with things like EPA and others where we have higher rates of having dumping places in areas that have more people of color that live in them. Our social networks, we have access to higher education, some groups more than others, but based upon social networks, and that is a power and wealth imbalance. And our tax policy will get certain tax breaks for certain communities that others do not get. So that power and wealth imbalance causes us the different social determinants of health inequities that cause unhealthy behaviors, that cause a disparity in disease. And in our country, in the U.S., we have three main root causes for those, and those are racism, classism, and gender oppression. And so it's important for us not to only problematize individual behaviors, but to really look at the root causes. And until we can explicitly have conversations about racism, classism, and gender oppression, we will continue to problematize individuals and individual behaviors and will not be able as a country to move forward and ensure that all of our citizens have the ability to live to their full potential as their human right. All right. So in order for us to really talk about racism, we have to have the ability to say the word without feeling nervous. It's not a judgment. I'm not calling you a bad name. It's not a moral complaint. It is a historic and a current reality that we have a belief in a hierarchy of human value based upon skin color. It's across the globe. And this belief causes us to do things that are both inside of our institutions, personally mediated and internalized. So Dr. Kamara Jones, a past president of the American Public Health Association, really has these three definitions that you could read, but also to give you a concrete example, when we have racialized Medicaid and Medicare. So when Medicaid and Medicare were created, this is an institutional racism example, in 1965, at that point, in order for the Southern senators to agree to pass a law that was a benefit, a health care benefit for people who were perceived to be black because they were people who were perceived to be poor, they wanted control of that benefit. And so Medicare became a federal benefit because the people are perceived to be white because they are perceived to have worked and retired. And Medicaid is still racialized. And to this day, you see work requirements that are created in places like Michigan for urban areas and not for rural areas. And so we still racialize benefits and cause harm where both people, there are both white and black people clearly who are on Medicaid. But the idea that it exists for one race causes us to then have the benefit that's not able to be beneficial for all. Okay. So we just want to make clear that race is real and it matters in society, but not how racists think it does. It's not genetics. Completed the Human Genome Project. There's no gene for race. It is not an ethnic group. It's not a population. It does not equal ancestry. Being from New Orleans, I can tell you there could be sisters. One could say she's white and one could say she was black, and they marry different white man and a black man, and their kids are different things. And so this idea that race had a biological basis has been debunked finally, although it's been in our textbooks for a long time. So why that matters is all of the strategies that we have currently for maternal mortality, thinking about it as a healthcare issue and thinking of the disparity as something innately wrong with black women causes us to choose remedies that are not based upon fact. Our original premise is off. For example, we know that black mothers who are college educated fare worse than women of all races who never finished high school when it comes to their maternal mortality. We know that obese women of all races fare better than black women who are of normal weight, so we can't crunchy our way out of it. That black women who live in the wealthiest neighborhoods worse than white women in the poorest neighborhoods, and then African American women who initiated prenatal care in the first trimester still had higher rates of infant mortality than non-Hispanic white women with late or no prenatal care. So if our only function, if our only choice is our prenatal care, that's not going to ever close the gap for how black women be able to survive in childbirth. So really, racism affects us both directly through chronic stress and indirectly. We have some, but the good news is there are some working successes. We have been research looking at working along with the Robert Wood Johnson Foundation, have a grant along with the American College of OBGYN. We also, we'll talk a little bit about that, created the Birth Equity Index, where we interviewed Black women to see what were the social determinants of health that impacted their ability to have good birth outcomes, and many of them included not having access to paid leave, not having access to transportation, not having access to a social safety net. We are a kindred partner with the Black Mamas Matter Alliance, which has Black Maternal Health Week coming up April 11th through the 17th, and we were able to be a part of the Preventing Maternal Death Act, where we've testified so we can finally start counting some of these maternal deaths. For the campaign Black Babies, these are the cities that we interviewed Black women in. This is a graphic around the Mothers' Voices Driving Birth Equity, along with the American College of OBGYN and the California Maternal Quality Care Collaborative, and really listening to Black women as we create both the questions and creating a patient-reported experience metric around what would a respectful care look like, and then how do we then hold systems and hospitals accountable for that. So both working on policy as far as paid leave, but also working on policy inside of hospitals to improve outcomes. This is articles we've written doing narrative shift, making sure that we no longer blame Black women for their outcomes and start with leading our conversations with lack of access to our deficit models around what we aren't doing, but looking at systems and structures. The countries that Heidi outlined in the beginning of this webinar that have better outcomes all have much better social structure than we do. So when we look for individual choices as to how we can improve outcomes without really examining the countries that do better, we are ignoring the opportunity in what we learn from those other countries. And we've also, like I mentioned, we have Black Maternal Health Week coming up, and there'll be webinars associated with that. Testifying in front of the UN about how this is a human rights imperative and how the U.S., although we can lead in a lot of things, we spend a lot of money on health care, and we don't invest in social infrastructure, and we have not committed to women and people of color having full autonomy as a human right and being able to have access to all the reproductive rights that we deserve. And so that shows up when we have the worst outcomes in maternal mortality. And this is the Black paper. We, as the Black Mamas Matter Alliance, released the Black papers. A white paper, Setting the Standard for Holistic Care of and for Black Women. You can find it on the website, and one of the webinars during Black Maternal Health Week will be the research group tied to this paper. And then the last slide, one of my favorite books is Stamped from the Beginning by Dr. Ibram Kendi, and it's the history of racist ideas in America, and he separates folks into segregationists, assimilationists, and anti-racists. And when you think about the work that we're asking you to do for maternal mortality, you think about paid leave, and you think about expanding resources for things like Jenny Joseph, her program, the JJ Way, that she's going to talk about soon, know that if you fundamentally don't believe that we are all equal and that you believe that somehow that people of color are broken or women are not capable, you will continue to cause harm for us in this movement. So we really need to be actively anti-racist to understand that we're all equal, and we have to invest in paid leave and not just improving healthcare systems if we're wanting to improve outcomes for Black mothers. And I think that is it.
Well, thank you very much, Joya. That also was excellent. I was glad to know about all those international standards we don't respond to here, but through organizing we can.
Yep. Thank you.
So thank you very much. We're now going to hear Jenny Joseph, who is practicing medicine, as I understand it. She's the executive director of Common Sense Childbirth, and she'll tell us about some of what she's learned about this whole issue through her practice and through her policy work. So welcome, Jenny.
Thank you very much, Heidi, and thank you, everybody. I'm very, very thrilled to be here and to have a chance to join in this webinar. I would start with just saying, you probably can tell because you can hear me speak, that I'm not from Orlando, Florida, but I've been in Florida for 30 years. I'm here, I don't know why I'm here, but I'm still here. 30 years later, I'm a British trained midwife. I am of West Indian descent. My parents are from Barbados and emigrated to the United Kingdom in the 1950s. I'm the eldest of 4 children. We were all born, raised, and educated in England. Everyone else is still in England. I'm the only one who ran away and found myself here. When I got here in 1989, I was already a midwife. I'd been a midwife practicing my skill, my trade, hospital-based, as is very common in the rest of the world, and working in a system where midwifery was normal. All women, unless they had high-risk issues, were seen and attended by midwives and expected to be cared for that way. But also, coming from England, I was also used to a socialized system, national health care, social support very strongly in place for mothers, babies, children, and across the life course. So I had no clue. I thought I was coming to Disney World, so you can imagine. So when I got here and tried to begin my work as a midwife, I had a hard time. First of all, I didn't understand about the history of midwifery, the grand midwives of the South. I was in the South and without any understanding of what had happened before I arrived in the late 80s. It's been a long journey, but to cut the story short, I became licensed as a midwife in the 90s. I was the first foreign-trained midwife in the state of Florida that got a license to practice. And over the years I've built a strong midwifery practice. I provide birth center care at the birthplace, which is a freestanding birthing center. I have easy access clinics where we provide women's health care. I have a school of midwifery where I'm training direct entry midwives who are able to do home birth and birth center birth. And I have a nonprofit organization which houses what we call the National Perinatal Task Force, because I've learned over these years here that this is a massive issue, and now on a national level, I'm trying to make an impact. I named the organization Common Sense Childbirth, though, for a reason, because it took me many years to figure out where was the common sense in the way we provide maternity care in the United States. And I still haven't really actually answered that question. One of the things that the midwifery model of care provides, and it's really basically a patient-centered model of care. It's a woman-centered model of care, family-centered. I've recently started saying that we are also providing trauma-informed care, because my practice focuses on centering women who are marginalized, women who are disenfranchised, women who are suffering, and who populate these statistics that we hear about, that we've talked about today. And, you know, even though I say this a lot, I speak a lot, I travel a lot, I hear myself, and I'm just incredulous. It still blows me away at this point that this is what we're talking about in the United States, this so-called developed nation, this leading nation. So our work has been really interesting in that providing midwifery-level care to any woman who wanted it, whether she wanted a midwife for real, whether she was actually clear about what a midwife was and why she would make that choice, or whether she just found that she could not get care anywhere else. We operate from a safety net perspective. We don't turn anybody away. And as the following has grown over the years, we've noticed that women come to us, families come to us, not necessarily looking for the midwifery care, but simply looking for an entry point. So we know that one of the most important pieces in engendering trust and having women feel safe, and safety is a big piece of our work, is that we are immediately open in a non-judgmental way. We move every barrier that we can possibly have any influence over, including health insurance, citizenship, financial means. There isn't anything that will cause us to say, no, you can't come in and get seen. And this is how, over the course of the last 20 years, we figured out that what we were doing was making a difference to the outcome. It wasn't that we set out with a distinct purpose. We weren't doing research. We weren't trying to make any specific study. We were simply providing the care. But the end result was that we found out, the outcome is so much improved. The low birth rate numbers dropped. The prematurity practically disappeared. Women weren't getting preeclampsia. Their diabetes was being managed, and they were going to term. Suddenly we saw this change, and we realized this could simply be because we're letting them in the door, treating them with respect, supporting them, and teaching that safety that is missing in what's happening here in the States. So one of our earliest studies that was conducted on our women was done in 2006. we enrolled 100 women prospectively into the program. And although the graph is pretty small, it may not be easy to read. But essentially what we discovered was, of the 100 women that were enrolled, and all of these women were the women that were more social risk or were not interested in the midwifery care, weren't looking for a natural birth, but were wanting the provision of the prenatal care, access to prenatal care and postpartum care. Those women were enrolled in the study. And of those women, we had not one who had a low birth rate or premature birth in that group. And that was against the year that the state and the county were running at 14 and 20%, respectively, for black women having premature babies. So that same time frame, the same demographic, the same women from our local area that were coming to our clinic had eradicated, we had literally eliminated the disparity as far as prematurity. Our babies that were born small were actually white babies, and we were less than 5%. So we knew we were onto something when we could see that those outcomes were so markedly different to the rest of the county and then the rest of the state. We've worked from there forward because we knew then, as I said, we were onto something, and we continued this work. The main tenets of this work is that we provide access immediately, unrestricted access to our services, that we also provide wraparound services. This is not just prenatal care, but we do what we call prenatal care plus. We make sure that the women have access to different resources, that we listen to what they state are their needs, and we try to make sure, like I said earlier, that we don't re-traumatize them, so we're doing trauma-informed care. So we provide access to support. The second tenet that is really important is how we try very hard to connect women to their baby, because most women who are scared and stressed and dealing with, difficulties are not going to connect to the baby. They do the opposite. They work really hard to stay disconnected in case something happens. Okay, so what we're looking at when we do our work is trying to make sure we have support for the moms to bond to the baby, but we want dads bonded, obviously. We want the siblings bonded, the community to bond to the baby, and also our staff bond with the baby. We are trying to make sure that there is no question that this child is valued. We make sure with our third tenet that we then educate women where they are. We meet them where they are, and we give them the knowledge and support that they need. They usually ask us, what do I need to do? And that's when we tell them what they need as far as their prenatal care education and postpartum support. And then we find that these women become empowered. Their agency increases and they can fend for themselves. We've written a report which has really outlines this work, and the title of the report is Building a Movement to Birth a More Just and Loving World. This is really where it's at. It's this intangible stuff that is not easily measured and not easily researched, but yet is making all the difference. And particularly we see that when we're talking about postpartum care. There's a dearth of postpartum. In fact, there's no postpartum care in the United States. Let's just be honest. A 6-week checkup doesn't really do a whole lot for you if you get a pap smear and they're told to get off that table. That doesn't help you. So we know that a lot of this work is based on listening and being available. So as far as when it comes to workplace and work policies, the women that we're working with, we are addressing this from the beginning of the pregnancy as part of their care, trying to help them troubleshoot, put resources in place for them, make connections in the neighborhoods, and so who can help with daycare and who can help with the pumping, who can help with getting the breast milk, what a work-friendly environment. We do all that work as part of prenatal medical care so that we make sure we're covering every angle to support women, and we found that those things are also key in making the difference in these outcomes. When I looked at the 2020 goals, which were a little bit more ambitious than the 2010, these are the goals that the federal government puts out every 10 years, it was interesting to me to see how we set these goals, and obviously policies are supposed to work towards getting them achieved. And yet I also stand back and sort of have my mouth hanging open at how audacious we are with these goals. The 2020 goals state that we are going to achieve health equity, eliminate disparities, and improve the health of all groups. And so, again, I come back to that question, well, where's the common sense? I can't see it. As I said earlier, I'm from the United Kingdom. There's been a lot difference in terms of how the British have tried to follow and understand maternal mortality. since the 50s. They were running their confidential inquiries and looking into death. But I also think it's important to notice how they've approached this. They have obviously improved their maternal health and mortality, as we heard earlier, but you could see in the report title, for example, by the 2010, they were calling it Saving Lives, Improving Mother's Care. In other words, that the information that they gather from maternal death inquiries leads to changes in how we do business and changes in how we deliver that care, changes in the policies and procedures that are going to keep women safer. It was really important, I think, to note just simple things such as language and intention make all the difference. So I just want to finish by mentioning the maternotoxic zone. That's a terminology that I've created just to sort of help myself describe better, but also to help perhaps get across to people what I think is also contributing to our problems. So a maternotoxic zone could be an area, such as Dr. Joya just described, the social determinants of health, maybe a violent neighborhood, a neighborhood without resources and support, structural inequities, and women are trying to have babies, are pregnant, are trying to breastfeed, are trying to raise children in those zones. Obviously, that's not conducive to their health or their best interest. But there's also the postpartum where the breastfeeding issues are really important. Breastfeeding is protective of our babies. Our infant mortality rates are also outrageous, and our babies aren't surviving that first year. But a breastfed baby has so much better chance. A breastfeeding mother has so much better chance. The mother-baby pair, that bond, is essential and protective of both of their health. The other thing to keep in mind is that the maternotoxic zones aren't just relegated to those neighborhoods, those poor neighborhoods and zip codes that we all know are of low income and are dangerous. But the maternotoxic zone can pop up anywhere a woman is if somebody or people around her are reacting to who she is, and therefore now the toxicity begins to seep into the atmosphere where she is. So you could have a maternotoxic zone in the middle of the most high-level perinatal hospital with every learned and experienced obstetrician surrounding you. But if you are being received in that way or looked at or ignored in that way, then the toxicity is there. And likewise in the workplace, when you have such oppressive situations, you're under such pressure and stress yourself, you're missing your child, you're grieving, your depression is beginning to worsen, this is where the toxicity again exists. The policies themselves, as far as I'm concerned, are often toxic, in fact, to the point of being lethal. And this is where I see the connection between maternal mortality and workplace and work policies. So there obviously are other ways to deal with these things. We've got lots of work to do, lots more research to do. But at the end of the day, I think it's common sense that we start looking at the holistic mother, the holistic mother-baby, and the environment that we have women and children in this country and the lethal impact on them when we don't have it together. Thank you.
Thank you very much. All I can say is, wow, this has been an incredibly rich set of presentations, and we're now open for comments and questions from all of our audience. See those question marks there? Those are for you.
We have two that came in during the talks. The first one was from Edgar Ortiz at Lane, and he was wondering about the connection between work schedules and work schedule stability and maternal health and reproductive health. I think Radha said she knew a little research on that. I should say that as part of this research hub, there will be some work being done around the schedule stability and childcare. So a slightly different take on your question. But Radha, do you have, you said you knew some research, or maybe Julia?
Yeah, this is actually Joya that I'm sure if it's Radha too. Go ahead.
Okay, sorry.
So this is Radha. Actually, that was the study that I mentioned, I guess, when I was, talking about previous work that I've done on postpartum depression, and I did find a relationship between access to job flexibility and postpartum depression. I don't think there's any research that I've seen on job flexibility and maternal mortality, but there's just a little bit looking at job flexibility and maternal mental health, as far as I know.
Yeah, there's some data about long work hours and infant mortality and reproductive health. So the longer, so we usually as OBGYNs kind of quote there's a certain amount of hours that we've shown through data that if you work a certain amount of hours, you're more likely to have infant premature birth. But we have not really ever focused on moms or women in this country, so there's not a lot of data around that.
Julia, did you have anything to add?
No, I think that the others have covered it. I think this really highlights another area where there's limited evidence.
I just wanted to add that we did a survey some years ago looking at families of different income levels and how they were dealing with the recession. And you won't be surprised to hear that when we looked into job quality, who has a kind supervisor who would give them flexibility or whose job has flexibility, it was white married men who had the most flexibility, and then it was on the job, and then it was black single parents who had the least flexibility on the job, arguably those who need it most because, they only have one parent to help them with flexibility.
Yeah. So the other question that came in earlier during the talks was a question about why these trends in maternal mortality have increased. I mean, we get that they can be high in the U.S. because we don't have any of the supports, but the question that Aoife Floyd wanted to know why, if anyone has sort of ideas about why they may have increased. I should say in the CDC data from the chart Heidi showed, some of it could be improved reporting. And that we're getting better data because, again, people are acknowledging that it's an important area to be researching and studying and understanding better. But if anyone has thoughts on why the rates are going up.
Jenny.
This is Robbie.
I'm sorry. Well, let's start with Jenny. I heard her.
So I was just going to say that the increase in cesarean sections over the last 20 months has had an absolute impact on the morbidity and mortality. You think that 1 in 3 women in the United States have surgical deliveries and then repeated surgical deliveries, then you create, and that would take, a physician or a hospital call was there before. Now women are at the stage where they're having to manage more morbidity. Their placentas may become stuck to their uterus. They have more risk of hemorrhage. Postpartum, they have more infection. We have no follow-up postpartum, as we said. They're getting medical care in the emergency rooms. They're back at work with a scar that's not quite healed. All of these things contribute to mortality, and I believe are the main reasons for the rise.
Okay, so you're putting it on surgical delivery and a lack of follow-up system. I do remember when I was visiting England how wonderful it was for my sister-in-law that the nurses kept coming to the house to check on her for quite a few weeks after the birth. And she was an older mother, so she really appreciated it. It was a little hard to hear you, so for answering the questions, if people could make sure they're speaking into wherever their microphone is, that would be good. And Radha, I think you wanted to respond.
Yeah, sure. So I think it's important to know that, the information we have about maternal death is flawed until now. And that's why, there was a maternal health legislation that was passed last year that basically funds state committees to review and investigate deaths of expectant and new mothers. Because we still don't know the specific causes of death and why this rising mortality is happening. Is it because of better reporting? That's maybe a small part of it, but there are other issues. So some of the thoughts about this that have been put forward in articles on this issue are increasing rates of obesity, delayed childbearing, increased cesarean delivery, as Jenny said, emerging infections such as the influenza H1N1, and untreated underlying medical conditions. So, so I think the answer to this question is we still don't know specifically why that's happened. And I think this legislation that funds states to look into it will probably give us better answers.
Joya,
this is Heidi. Sorry. This is Heidi. I was just going to add a small point that women are working more. More women are working, and they're working more hours, and that could increase stress and increase the inability to get medical care. And certainly since we first started tracking this in 1987, then about 1990s, the amount of work started to level off. That is, the share of women working leveled off, but not the hours of work. Those are still going up. So that's one factor. And I'm not sure who to call on next, but Julia and then
Joya. Yeah.
And then Joya. Okay, Joya, you may start.
Okay, yeah, thanks. I just want to make sure that, so they've done, CDC and others have done a lot of testing to see if it was about increased uptake of that research, and that's not, it's been proven a couple of times not to be why we see the difference between, because we've been counting since the 1930s, and so it didn't just start counting in 1987. We did, prior to 1987, make a proclamation as a country that we had cured maternal mortality, and so we stopped counting as a commitment. It was really done through the American Medical Association and through hospitals and doctors, and it was something that was kind of run through states, and we stopped focusing on women. And as you know, what you don't count, what you don't pay attention to, can become a whole other issue. And so part of what we see now is really the country, including the bill that I mentioned and that Rada just mentioned, us trying to ensure that we actually count women, to give a global framework of other countries count women and they don't necessarily count babies. We require this country to count infant deaths, but we don't require counting maternal deaths. And we make a lot of excuses as to why we can't make that requirement, but then we see our numbers being an international embarrassment. So at some point we're going to have to make a commitment that we want to really pay attention to and put numbers and invest in research around why women are dying, so we don't have to come up with kind of our theories, but we really have accurate information.
Wow. And Jenny? No. Julia, do you have something to add?
I don't need to add any more on top of those great answers.
Okay. Well, as you all know, as an economist, we can tell you that what is not counted is not important, and there are countries around the world who are doing a better job not only of counting this issue, but counting everything. The amount of unpaid care, which again adds stress if your work hours are going up, and you're also doing unpaid care and you're in the sandwich generation. All these things that we don't count in this country, you know, are undoubtedly contributing to this problem. So thank you very much for that, Joya.
Yeah.
So we have a question on the federal policies. Rada included a rundown of some of the recent proposals at the federal level in her presentation. Of those, the Family Act would set up a social insurance model and be the most universal. The others are either, you know, some of them are that you could borrow from your Social Security, make a claim, and then sort of delay your retirement or take a pay cut in retirement. It would be fairly low payment, and we know from places like California that if it's not well-paid leave, we talked about, you know, the idea that most of these policies only do partial replacement, that if it's not pretty well paid, people won't use it. And so most of the policies that were on the list that Rada showed are going to be fairly probably spottily implemented by states. If they're the links to the one that's linked to the UI, the unemployment insurance system, would be up to states to implement and things like that. So most of the federal proposals are really probably not that universal, and all states probably would not implement them evenly for that question.
Yeah, and I would just add that our research shows that, we know the Unpaid Family and Medical Leave Act doesn't protect anyone who works at a business of fewer than 50 employees. Mm-hmm. And what we find in the states that do have paid leave is that it bumps up as soon as the firm is over 50, more usage of it. And that's because people cannot afford to leave their jobs, lose their jobs if they take this leave. So, we have heard, terrible stories of women going back to work in 2 weeks after the birth in order to not lose their jobs. And also in one place we heard that that's how you get to keep your child care slot for the older child. Mm-hmm. Let's say you have a 2-year-old, you want to keep her in child care. She's got to go to child care every day, and if you're a single parent, that means you've got to get out of the house and probably go back to work, because your child care slot is very valuable, but it might not be fully paid, so you have to have some money, too, to be able to finish paying your share. So it's a pretty brutal system, I would say, that we have here for new mothers.
Yeah, this is Julia. I would just add that I think we have a couple of bills that were discussed at the federal level, but right now, at least in the short term, the momentum is really at the state and local level. And those policies are mostly, I guess they vary a lot in sort of who's covered and how generous they are. So, for example, California's, I think, is down to employers of 5 or more employees, but others will cover only larger workplaces. And then those are layered on top of, as Heidi was saying, the job protection from the Family Medical Leave Act, which is pretty restrictive. So there's in the state policies, I think we've already seen and will continue to see a lot of variability in who's covered and how generous those benefits are.
Yeah, that's a good point. And California is in the lead there with going for very high benefits, particularly in San Francisco. But the governor is now saying he's going to get fully paid leave or close to fully paid leave up to 6 months for new parents. So there are some definitely very exciting things happening at the state level. And, that means the federal plans can't be more than, 2 or 3 decades behind.
More decades.
But seriously, what we really need is more job protection. And unfortunately, we haven't been able to get that through the federal level, but some states are definitely stepping up to a better standard there.
The next question's for you too, Julia, so stay on the line. Bridget Schulte wants to hear more about the study you did in Multnomah County and the cultural context of implementing policy and the differences in using the leave, not necessarily the access, but especially in using the leave that you found.
Yeah, so we did a multiple method study. So we were looking at the policy that was implemented within the county where Portland, Oregon is located, and there's about 5,000 employees at the county. We did a survey of all county employees. We did focus groups, and we also looked at administrative data, looking at timekeeping records to track before and after this paid parental leave policy that they implemented, who was changing their leave-taking behavior. And a couple of the really interesting findings, I think, were around gender differences and how people took leave. The one interesting finding is that when they implemented this paid parental leave period, mothers' leave-taking didn't actually change that much. It's just that they now had a lot more of their leave that was paid. They were taking as much as they possibly could before. And so this policy allowed them to get paid for a longer period. Whereas for fathers, they took about 6 weeks more leave than they did before. And this is consistent with a lot of evidence that men generally will only take leave if it's really highly compensated. So that was something that we found. But then what I was alluding to is that, especially coming out of our focus groups, we saw a lot of differences in how people actually experienced the leave that they took. And we didn't find that there were huge differences in the amount of leave that people took based on their supervisors and their coworkers and the support that they experienced. But they did report feeling resentful of their employer versus, some who said, my supervisor was so helpful and really worked with me to, go out on leave and come back on a reduced schedule. And those sorts of things made them feel much more loyal to their employer and much more excited about coming back to work. Whereas those employees who said, yeah, I could take my 6 weeks because that was guaranteed to me, but nobody worked with me, nobody gave me information, and that just, really rang differently for people. And so these are some of the things I think you don't capture in some of the bigger studies looking at, state-level policy change. You don't see how these are actually playing out on the ground and how they're different for different kinds of workers. And this is certainly something that we saw across different departments within this one organization, different job types, people who said they were sort of on the front line versus those who had desk jobs that they could be away from for an extended period. So those sorts of considerations I think are really important to include in this conversation.
Well, thank you very much, everyone. I want to go back to a comment that Mary Jory made, that states are now incorporating more guaranteed right to return to your job. Sorry, Madeline Jory. And yes, that is true. They are stepping up some of the states. And there's a lot more potential for more action by states. So that is a bright spot in this landscape.
So the other question that's out there in the window is, what other sort of resources would you recommend to people who want to think about this topic more and learn more about the topic? Should we go in the same order? Maybe start with Julia.
Yeah.
Okay.
I mean, I think there are a lot of organizations that are doing great work on this. Obviously, IWPR is putting out great information in this space. National Partnership for Women and Families has done a lot of work tracking, both gathering information from other places, but also tracking state level and federal policies to sort of keep up to date with what's going on.
Okay.
And Radha, anything you would like to mention, maybe on the health impacts?
Sure. So right now, actually, NIH is very interested in maternal mortality and disparities in maternal mortality, and there are working groups that are, meeting regularly to discuss this and figure out, ways to improve the research based on this topic and figure out what's happening. And so there will be, I think, community engagement forum on April 8th that will discuss maternal health and maternal mortality. And I think there is also a couple of days in May that NICHD is also having I think it's a workshop or a 2-day workshop on the topic. And so I think, going to the NIH website and looking up and following up what's happening there, I think you could also find some resources related to that. So,
well, Radha, that's great, Radha. We'll look for that community engagement forum, and if we can't find it, we'll call you because we'd like to put that out to all the people who
I can forward that to you. I can forward that to you. I have that. Yeah.
Wonderful. And Joya, anything you would like to recommend?
Yeah, I try to put in a couple of plugs in my talk. But so for the Black Mamas Matter Alliance, if you go on our website, you'll see Black Mamas Matter Alliance. That we have Black Maternal Health Week coming up, but we also have resources including a policy guide and the Black paper. Our hope is that you will think, because I think on this webinar there are a lot of people who are lawyers and policy folks and thinking about how do we really think about health and healthcare as a human right, and how do we make policies and embed policies that are just, and looking at reproductive justice as a framework for how we can improve outcomes for moms. And that way we don't have silos, because for me there's no difference from me talking about implicit bias training or anti-racism. And the name of the book is Stamped from the Beginning. It won the National Book Award last year from Dr. Ibram Kendi. He was at the Anti-Racism Institute at American University. But for me, there's no difference from working on anti-racism and also working on paid leave policies. All of those things are embedding us, reframing how we think about people in this country and valuing everyone despite race, ethnicity, religion, culture. And what would make us truly exceptional as a country is if we were able to then show that we can have these policies like Finland and Sweden that have good outcomes, but we have a very diverse country when it comes to all these other race, ethnicity, and all culture, language. So that's it.
And Joya, someone would like to hear more about the human rights aspect and maybe where they could go to get more information about that.
Yeah, I mean, look on the BlackFarmersMatter.org. Also, Sister Song, it's another reproductive justice organization. We work with the Center for Reproductive Rights as well. So they're really thinking about human rights and how that impacts our reproductive rights and reproductive justice.
Great. Thank you. And Jenny, would you like to add something?
Definitely echoing the Black Mamas Matter Alliance as definitely a great resource, just cutting edge and moving forward now with this particular issue. But I think internationally speaking, there's been a lot of work overseas on respectful care, and that immediately centers the woman and brings the humanity back. And so the International Childbirth Initiative, the ICI, has just been ratified by the International Obstetricians Organization and the other childbirth organizations are looking at it. If we just respect women across the board, pregnant women, parenting women, we're going to see that this is going to become part and embedded into how we think about everything to do with the women and their health and their mortality. So I think that we look at international work that's already being done and try to keep moving it forward back to, or moving it backwards rather, into the United States. Kind of sounds crazy, but that's how I see it. People have already got this all taken care of, but we are just lagging and not really willing to open up to this way of being. And so there's a lot of work out in the international field that I think would be helpful in this system.
Thank you. And Joya, there was one question about the source for the anti-racism work.
I think she...
Radigated.
No, that's Joya. She's actually labeled as Rada.
Yeah, I'm listed as Radi. I typed the name of the book in there.
Yeah, it's right here.
Oh, okay. It's typed in.
Yeah.
Great. Okay. I want to mention one thing that I think could be done much more of, and believe it or not, the D.C. government is so for hesitating to do this, and it's to form one of those task forces after there's been a death to have that particular event studied by a interdisciplinary task force. What caused that death? What can we learn from it? What can we do about it? We haven't even agreed to do that in the District of Columbia, but hopefully some of you will know about progress in other jurisdictions.
Yeah, DC just started theirs. They just had their first inauguration thing a couple of weeks ago.
Great. Okay, good. Because I missed that headline. I caught the earlier one. I also want to mention A Better Balance is another organization that keeps good track of these things about the progress of parental family leave and paid sick days. And many people in the U.S. don't even have one single day of paid sick leave that they can use for a doctor's appointment. So I think we're going to wrap up there and just thank our presenters so much for an absolutely wonderful webinar, and thank all of you for participating. And yes, you do know where to find us, so I'm sure if you have continuing comments or questions, you'll send them to us. But what is our address? Is it info@iwpr.org?
Yes.
Our general address?
Our general address, yes. And we'll also follow up. We're going to make the PowerPoint presentation available as well as the recording after the webinar. So we'll follow up. So look out for emails from us.
Well, again, thank you all, and do come to our next webinar, which is the last Friday in April.
April 26th.
April 26th, same time?
Same time.
3 p.m.
3 p.m.
To find out more about the infants involved in neonatality deaths. So again, thank you all very much.
Thank you for having me. Have a great day.
Thank you for having us.
You're welcome.
Bye. Have a good
Bye,
weekend.
everyone.
Bye. Bye. Bye.
Thank you. Please stand by.